there are many different modules of EFFT. There are 5 of them to be exact. Sorry, I'm a little distracted by letting people in. I'll get the hang of this. So there's behavioral support, emotional support, therapeutic apologies, emotional blocks in caregivers, and emotional blocks in clinicians ourselves. If you're newer to EFFT, these may all seem like faraway concepts. Maybe you don't necessarily have a grasp of them. So I do want to invite you to seek out further resources. We have a ton of free resources on mental health foundations, both in the caregiver section and the clinician section on all of these different topics. As well as we have some upcoming trainings in the coming weeks that I'll talk about at the end of the day. But I wanted to show you an overview of the model, because sometimes what happens when people are newer to the model, this happened for myself when I was a new trainee with EFFT, it's like you get the different pieces, but then you wonder, how do you put it all together? And so actually, sorry, everybody, I'm just going to pause because Lisa, who's one of my supervisees, just very kindly offered to manage the waiting room. And I'm going to make her a co-host so that she can do that for me. So sorry, everyone, I just need to simplify this. Thanks, Lisa. I really appreciate that. Sometimes the big question is like, I get all of the components, but how do I put them all together? And behavioral support, we know, for recovery from mental health concerns is so important. But then emotional support is also really important, because if someone's emotionally dysregulated, they're going to be using symptoms in order to cope. And so when we take away people's symptoms, they're going to end up being emotionally dysregulated. So it really is a balancing act of both. And then what happens if there is a rupture in the relationship, or maybe the caregivers are doing everything under the sun to support their loved one, and it feels like it still needs an augmentation. Like it's a highway, lots of stuff is going really quickly, but we want to make it a super highway so that we can have more impact of the interventions that are used. That's where we pull in therapeutic apologies. And then of course, we are human beings. And so caregivers, clinicians, there are going to be emotions that come up at some point: fear, shame, self-blame, hopelessness, helplessness. And so those need to be worked with as well. But where do we start? Well, before we dive into the actual case conceptualization tool, I want to show you one of my favorite slides in all of the trainings, which is the fundamentals of EFFT. Because even though there are recommended ways to use the model, there are some underlying fundamentals that if you are leaning into them and practicing them, you are already doing a phenomenal job at EFFT. And so these are the fundamentals of EFFT. First one being family focused. I know for myself, when I was a newer practitioner, and I see this a lot with people who I work with, sometimes we work in systems that are quite individually focused. And so we focus a lot on the individual or the person who's in front of us in the room. And so with EFFT, we invite you to broaden the focus and look at the family and all of the different players, specifically, the caregivers and the individual with whom is struggling with the diagnoses. The next piece is caregiver empowerment. I like to think of it as shifting the energy of our no wonders. So I'm sure we've all at some point in our careers met a client and we hear about their upbringing or what's happened with them between their parents, and we go, no wonder. And I like to shift it to imagining what must be going on for the caregivers and all of the emotions that are coming up and all of the reasons why they're presenting the ways that they're presenting, and shift the energy to no wonder. Like, no wonder that caregiver is struggling to support the child in the best ways possible. No wonder things are unfolding as they are. And that shift from like, no wonder, no wonder the kid's messed up, or no wonder, the child is struggling, to no wonder the caregiver is having such a hard time, can change everyone's nervous systems for the better. And if you're like, but what about the parent who does this? What about the parent who does this? I invite you to dig into the caregiver block section of EFFT if you haven't already, because we talk so much about caregivers who do present with unhelpful behavior and caregivers who are presenting with therapy interfering behaviors. And there are a ton of interventions that we can use in those places. So if you're like, oh, I want to know more about that, there is a webinar on the Caregivers page. There's actually a 4-part video series that I did. It's the Prevention Parenting series. I'll pop it into the chat box later. And there's an actual video on caregiver blocks. Similarly, the video section of the Mental Health Foundation's page has a couple of webinars I did on caregiver blocks. You'll get more information there. The next piece, piggybacking on the back of that, is focusing on emotions and emotion processing, both in the patient and in the caregiver. And so really supporting their emotional process. We look at it as a cascading effect of attunement. So if we're able to support the caregivers with their emotions, support their nervous system to regulate more, they'll then be more able to support their loved ones' emotions and their loved ones' nervous system to regulate more. And if I can just blow it out a little bit, I think that if we can go one step higher to supporting our own emotions and our nervous systems to settle more, then we can better support the process for the caregivers and the loved ones. The next piece is skills training. It can be really easy to fall into a ditch of either doing all skills or all emotion. But at the end of the day, caregivers can have an incredibly settled nervous system, but if they don't know how to, express support to their loved one, or, specifically emotion coach, then what are they going to do when they leave our office? And so also teaching caregivers skills that they can apply to supporting their loved one. The next one is 1 degree effect difference from baseline. I think sometimes what can happen is that we see all of the possibilities of interventions and skills, and we see a caregiver and a family who could deeply benefit from those skills and interventions. And then we try, and it feels like it's not working. And so as a newer EFFT practitioner, I saw this whole model and I was like, I'm going to do it. And then I'd meet a caregiver who had trauma, or, had intergenerational trauma, or was under-resourced, or was living in an extremely oppressive system and was a marginalized individual. And getting them to go from 0 to 100 was not possible because of the barriers and the lack of resources and the implications in their system from the amount of oppression and trauma that they'd experienced. And so the idea of we're going for gold, but in extreme cases, look at where the baseline is and then go for one step beyond that. I wish we had time to talk about how this looks. Maybe I'll do another webinar about, EFFT in extreme cases down the road, because there are so many different ways to get creative around what that 1 degree can look like for a caregiver and a family. And I think sometimes in our system, it can feel like, well, 1 degree isn't enough. Just getting them to shift a little bit isn't enough. But if you think about an airplane, when they flew around the world more frequently, leaving London, England, going to New York, and if that flight path is off by even 1 degree, it doesn't seem like a lot in the beginning, but over time, the trajectory will actually leave the airplane somewhere far off their set destination. Maybe they'll be in the middle of the States or in the middle of the Atlantic Ocean. And so similarly with trajectories for our families, for healing, it may not seem like a 1 degree shift is a lot, but if that 1 degree shift is sustainable, it can make an extreme change in the long run. And the last piece, which I am obsessed with, is transparency and collaboration. Allowing the caregivers, allowing the client to be essentially partners in care. And so collaborating with them about it, but transparency being things like, maybe you learn a new intervention that you want to try out with a caregiver or with a client. And you're sitting there being like, I don't know, they have a lot going on and I'm worried about stressing them out. And what if I do maybe this chair work thing and they end up getting more dysregulated and then they have to go back to their really demanding life. So I think sometimes what can happen is we can get really caught up in the what ifs, and we don't consider that we can just have a conversation with the person and allow their inner healing intelligence to shine through. And so what I like to do in those situations, for example, with a parent would be like, hey, I have this intervention. I think it could be incredibly helpful, but it's pretty intense and it will take up a lot of our session. And I know that you have a lot going on right now. I wonder if we could just take a moment and check in. How are you feeling today? Do you feel like you want to walk through a swamp today? Or do you feel like you need a little more resourcing and grounding? in order to get you through the week? Like, what do you think would be most helpful? And then decide together how to proceed forward. So I think about EFFT as like 50% following and 50% leading. We have the map with different possibilities, and then we collaborate at the touch points with our families, with our clients around what fits for them. So those are the fundamentals. And I'm sure that even if you haven't had EFFT training, many of you are already engaging in so many of these. And these are kind of just those pieces that hold the model together. And I'm not going to go through methods of implementation too much, but I just want to show you this because the case conceptualization tool is really looking at when we're working with caregivers and doing like caregiver only or caregiver separated from client EFFT. But there are a lot of different ways of accessing EFFT for caregivers and for families. And so you can absolutely increase the support that they're receiving by, also offering groups and also offering different ways of applying the model. So even though we're going to be talking specifically about working with caregivers with the case conceptualization tool, I want you to see that there are other ways of engaging also. So without further ado, let me just pop up the case conceptualization tool. So I did put it in the chat box. I'll pop it in there one more time for those of you who came in later. And again, if you have a version of Zoom where maybe you're unable to download this, I will be sending this out to you over email later on today. But this is the tool. This tool, in my experience, kind of replaces the 3-session model. So any of you veteran EFFTers here, there are a number I can see. One way that we helped everyone understand the model in the early days was with this like short-term applications 3-session model of EFFT. And I certainly supervised a number of people in that model, and I think it's a great model. And in my experience, it kind of mimics the caregiver workshop, but in parent-only session form. That said, it didn't fit for everyone. Not everyone is short-term cases. And sometimes we needed more than just one caregiver in there. And sometimes we needed to focus on particular parts of the intervention more than others. So the case conceptualization tool is really a opportunity to plug in the information that we have and then choose your path from there. Kind of makes me think of those novels. I don't know if any of you remember. I remember in elementary school, they used to have these novels where it was like choose your own ending. And I used to love getting those ones. So you get to a certain point in the book and then you can make a choice and then you flip to certain pages. The case conceptualization tool for me feels like that. So you get so far, and then based on the information that you have, you can make your choices using your clinical expertise and collaboration from the family from there. So we are going to go through this, and then if we have time, I'll invite someone to maybe plunk in a case and we'll go through it together. But I just want to show you the whole tool first. So number one in the case conceptualization tool is identify adults who care about, provide caregiving, or are responsible for the welfare of your client. Rank order these adults according to their neurological power. So you might be wondering, what do I mean by neurological power? So generally speaking, the person who did the feeding in the first, year of life is going to be the most powerful neurobiologically. And then the person who spent the most time, thinking of attachments and then going on for there. That said, not everybody is going to be with their families from the first year of life. We're going to be working with some kids who are in foster care, or maybe some kids who are living outside of the home, or maybe you're working with adult children and so on. And so we're looking at whoever has the most power. I think of it in terms of oxytocin, like who has that love bond. And I'm going to rank order them top and then go down from there. The other thing about number one is that just because you put people on the list does not mean that you actually need to include them in the therapy. What it does mean is that as you are doing the therapy, if you are not having the desired outcomes from using all of the interventions available, it would suggest that pulling in another caregiver could be highly helpful. So say we have, an adolescent child who's living at home with one parent and they're their primary caregiver, we are going to put that parent as number one. Say they're seeing their other parent part-time every second weekend, and that parent, of course, someone else who's important to them, even if it doesn't feel to the adolescent at that moment that they're important, we know neurobiologically they are, we'll put that other person on the list. Other people to consider for the list would be like school counselors, youth workers, grandparents, other people on the clinical team, teachers. We've certainly had it like family, friends, uncles, aunts, and so on. And so I like to sit down and think of my case and think, if we need to have all hands on deck, who are the hands that we can have on deck? I feel like this gives you such a picture of the resources available and also the stress on everyone's nervous system when there are less resources available. So I'm currently working with a case where it's a single parent, the other parent is not available. Due to COVID, there have been considerable lack of access to resources. Like they're on like 8-month-long wait lists for the child to receive mental health care. Child is in and out of hospital for symptoms, but there's never anything offered beyond like those ER touchstones because they're on wait lists for all of those things. And so we literally have pulled on for caregivers, like neighbors, to help making dinner for the parent so that the parent can have like 30 minutes to just breathe and kind of like reground herself, because she's also working a number of jobs to try and provide for the family, and so on and so on and so on. So sometimes we have to get creative in number one, and sometimes you don't need to move beyond number one. So you may be working with a family where you meet one parent and you're working with a child and you're teaching the interventions, and the child is finding relief and is progressing towards health with the support that they're getting. So you never need to actually go beyond number one on the list. Similarly, you might be working with a family where you're working with that one parent or two parents and you're doing all of the interventions, and there isn't the relief for anyone in the process, and people are finding that they're getting burnt out and there's more desperation. And so that to me would be like, okay, who else can we pull into the picture to supplement? And people who you pull into the picture do not have to be perfect, and they do not have to be, up to the caregiver's standards for care. I think that's also an important piece of it. Sometimes it's almost just like having a warm body there with the client so that the parents can say like, go for a walk or go to a yoga class or go do their own work or just sit and stare at a wall. Like seriously, sometimes it's having somebody there with the child, doing something fun with them or having a meal with them. And then other times it would be including that person more so in the interventions. So that's that piece. Does anybody have any questions on number one for the tool? Feel free to type them in the chat box or unmute yourself.
Is this, hi Natasha, it's Mike.
Hey.
Is number one, is it co-created with the client or the parent, or?
Great question. Yeah, that's a really great question. So this tool can be used just kind of sitting down, getting a bird's eye view yourself as a clinician. If you do know a lot of the family, if you don't know a lot about the family, I would definitely sit down and co-create with the parents. Similarly, the child might think of some people who are a resource for them. And so I would definitely be pulling in the wisdom from the family as well. Yeah. One thing that I like to do is I like to sit down with this before going into a session and kind of fill out what I know the best possible, and then bring it in. And I don't necessarily give the form to the parents. And it's not because I'm trying to keep it a secret. Like I'll show it to them, but there's just stuff about clinician blocks on it that like they don't need to worry about. But I'll kind of go through, fill out, especially the first page, and then come in and be like, okay, so I was just reflecting on the big picture and the specifics of where we want to go. And I wanted to run some things past you and get your thoughts also. That's how I'd probably do it. Yeah. Okay. Number two, identifying the presenting problem or problems of your client. Rank order these problems in order of severity, need for attention. So there's a couple of things in terms of severity, need for attention. Number one is that whenever a problem is like life-threatening or significantly impacting life functioning, I would put that as a number one. So things like purging, severe self-harm, anything kind of eating disorder related that's especially, symptomatically not safe in the body, running away, like those types of things need to be number one, like no questions asked. Things, for example, if you have a client who ADHD, school refusal, and social anxiety, those aren't necessarily like in the moment immediately life threatening. And so you can kind of step back and look more at, okay, what do we have more ease of maybe addressing and what makes more sense? So definitely use your clinical wisdom here. And similarly, you can collaborate with the family. So maybe you make your list and then you go in with the family, or depending on the age of the child, and check in, like, this is what I was thinking. What would you add to the list? Did I miss anything? Do these feel like the main problems right now that we're dealing with? Are there other problems? Sometimes we can get really diagnosis centered, and then the parents will be like, whoa, whoa, whoa. The biggest problem is that every night my kid, like throws their plate when they get mad, or like they beat up their sibling, or they like have a significant meltdown before bedtime, or so things that maybe are like grouped under the behaviors with a particular diagnosis, but maybe they're not a diagnosis. And so there can be flexibility here, because I like to think about what is on the parents and what is on the client's radar. So even though maybe it doesn't have a title in the DSM, if there is something that is causing a significant amount of distress, or I also think of it like a huge charge in the nervous system, like they're like dreading it or thinking about it, then I think that kind of deserves a spot on the problem hierarchy. So things to think about like that. And again, you can absolutely collaborate. And depending on the makeup, I say, like with the parents or the child, some of you are working more in like full family therapy, and so you might come in together. I usually will work parents only for the few sessions, and then bring in a child after I've kind of like taught the parents some skills, connecting with them, got the picture. And so I would be talking to parents, and then as I brought the child in, I would be collaborating with them in their own session, but it really depends on where you're at in the work. And the other thing I want to say is that some of you may have been working with families for years, and maybe you're like, oh, like this is helpful. You can totally bring it in. That's where that transparency part of EFFT comes from. So I just be like, hey, I went to this training and I got this new tool, and I think it would be really helpful for us to just pause and conceptualize where we're at and where we want to go. Like, are you game? So it can be a really nice reassessment. And I use it a lot in supervision with clinicians to do that when they feel like they're a little bit like lost with the case, because can't that happen? I know I find sometimes I can go in and like have a really set plan, and then life happens and chaos happens. And we've been trying to put out the same flyers week after week, and it feels like we haven't actually addressed any of the reasons why they've come to therapy. So it can be a nice little reset. Okay, so after we identify those presenting problems, rank order them, we've talked to everybody around like severity, need for attention, what our goals are, what we're working on. We then look at the behavioral strategies recognized as best practice or promising practice to address this problem or disorder. So I think this is another reason why I have like a huge love for EFFT. No one model is going to be your fix for a human being. Like, I mean, sometimes one model can be how we get there, but the reality is that human beings are complex, and there are so many different ways of addressing the same presenting problem. And I think that we can benefit from considering, especially behaviorally, what some of the recommendations are. And so with EFFT in the behavior coaching category, we sure have some like recommendations that we usually glue emotion coaching to, but the recommendations that we're making are specifically from what the recommended best practice or promising practice. These are behavioral strategies for various mental health issues. And it's definitely, excuse me, not covering every mental health issue, but some of the common ones that we work with in practice. Make it a little bit smaller so you can see it all. These are some sample tools and strategies. And so these can be recommendations that inform the behavioral strategies. I've actually had some clinicians who worked at clinics around particular diagnoses. And so they have fleshed out and made like kind of an all-encompassing list of behavioral tools and strategies. And that has been helpful for them. But if I can just speak transparently myself, I don't know about you, but I feel like when I first got out of grad school, I like could tell you all of the behavioral recommendations for like every disorder under the sun. And then the deeper I got into the work, I like And the more I got into embodied work and looking at things like chair work and, really having an impact on embodiment in the session, I was less focused on behavior. I was less sharp. And so I remember somebody one day being like, okay, so like, what are the best practice recommendations for this diagnosis? And I was like, oh, can I Google that? So if you feel like that, totally no judgment. I'm also part of me is like, oh, people are thinking like, why is this girl talking? Like, what does she know? Anyways, that's my own shame. I'll just deal with it. But I just want to let you know that it's okay if you don't know everything. And it's okay if you don't know the best practice recommendations. And now is the time to maybe brush up on that. And hopefully this list can be a jumping point for you if that feels helpful. So some things are going to be quite similar, things like sleep hygiene, medication adherence, appointment adherence, establishing routines, and so on. And then others are going to be really disorder specific. And so what I would recommend doing with the case conceptualization tool is did I share it with you? Yeah, I did. Taking a look at the behaviors and problems you've put up here, and then making your list of best practice strategies down here. And now it says ... because there's probably going to be more that you flesh out. Similarly, I would rank order them. And honestly, whenever I rank order anything, I look at what is necessary now around like life-threatening. But what I'm looking at more is what feels the easiest to implement. Like what will be the most accessible? Because I'm thinking of caregivers and clients feeling like they actually have success and like they can develop mastery over something, and that maybe change is doable. And thinking about that idea of working with the person's nervous system and having small doable steps and 1 degree. And so as you're looking at the strategies, some of them are going to feel harder than other ones. I would look at, okay, what needs to happen now because of life-threatening and quality of life, but also what's the most accessible? And then starting with that and then going from there. So as you can imagine, you're not going to throw all of the strategies at the caregivers at once. When I work with caregivers on this, generally we pick top priority, top behavioral recommendation. And then as you'll see in here, we look at the actual micro skills of implementing those changes with their loved one. And then we go from there. So it's kind of like as many as you can do at a time within a doable way that will actually be sustainable. Because I'm sure we've all had the experience where we see everything that needs to happen. And maybe we even have a session where like the client or the caregivers get really excited about all the things they need to do. And then they do it for like 3 days. 3 seems to be like the day where if you can get beyond 3 days, you're creating sustainable change. If you're like white knuckling the whole time, usually 3 is the amount that I find myself or families I work with can kind of muster. And then it's like, okay, I can't do this anymore. And so I'm sure we've all had the experience where people get really excited and then like they rush out of the gate and they lose fuel and they come back the next week and they forget what you even talked about. And it feels like the whole world is burning. I'm a bit like that in my own work. When I see what I've got to do, I'm like, okay, I got to do it all now. And so my own actual growth edge in the world right now is pacing myself in a way that is sustainable for my nervous system. So it's not like go, stop, go, stop, go, stop. And so when you're setting these goals, having really transparent conversations like, okay, so I know you're excited about all of these things. I also want to recognize that not all families are going to be stoked about all of these things, depending on, all of the barriers that they're experiencing. But for people who are like, okay, we've got the list, let's do it. Have really candid, I think that's the word, conversations around, okay, I know you know how to do this, but let's think of your life. And let's think of all of the roles that you take on outside of being a parent for your loved one and supporting them in their mental health recovery. And let's think of the availability of capacity that you'll have at the end of the day. And, if you can tag team with each other, if there's another parent, or who's going to tag you out so that you can take a break and so on. So really having those conversations and doing as many strategies as you can within a doable level of capacity. All right, let's continue onwards. So this is where we're looking at kind of caregiver only sessions beyond, these conversations, because I never want to put caregivers in a position with their loved one where it looks like they don't know, like they have no clue what they're doing, or like their fears are the number one thing that we're looking at. So we always say with the model of EFFT, we want to share everything with the kid, what the parents are learning, accept their blocks, their fears, their shame, and their maybe like inside reactionary voice. So in a caregiver only session, what I would then do is I would work with the caregivers to learn how to do these behavioral strategies in the home setting. I think sometimes what can happen is that in that kind of individualistic approach, which is much of mental health, we can work on these things with clients in our 1 hour a week session, if they're lucky with our busy schedules. And then they go home and it just doesn't get any traction. And it's because like no one in the home environment knows what's happening. And it feels really vulnerable for the client to share with the parents and then have the parents not quite understand it and so on. And so it doesn't really go anywhere. And so what we do is we actually teach the caregivers the tasks to implement at home. And this will look different depending on, if you have a 6-year-old or a 16-year-old, and where they're at developmentally and emotionally, and how implicated they are by their symptoms. And so I absolutely have had like a 30-year-old client before who the caregiver was doing anything and everything. And the 30-year-old client, was so debilitated by their mental health concerns that we weren't having conversations about what they needed. Like we were getting the caregivers to do it, to kind of nurse them back to health. And then they became more of the conversation. On the other end, you may have, clients where you've been working with them individually for a long time and you're just now pulling in the parents. And so what the parents are doing in the home setting might look a lot different. Like they might look more like the supporting role than the primary role. So just things to consider. So teaching them these particular behavioral interventions, something else that you can do, which we kind of talked about up here when it came to presenting problems, but you can help caregivers develop their own list of behavioral targets. And this is the prompt that you can use. So the prompt that you can use for this particular piece, but just also in general, what does your loved one need to do more of or less of to get on track with health and wellness? So quite often I'll have parents brilliantly come up with things like spend more time in nature, which like I could be wrong, but last I checked, I don't think that's in the DSM anywhere. Or things like, coming when it's not eating disorder, like just like having a family meal a few times a week, or having a family games night, or whatever else. And so these are things where caregivers, based on their own relationship with their loved one, can really bring in their wisdom. And then, less screen time, like Kathy just said. So things that aren't like explicitly listed diagnostically, but that would bring about so much ease. So just not, that I'm dealing with this, but in my own family, I have a 6-year-old and she has anxiety that we're working through. And one of the things that we've added in is that every night we have a dance party. It's like a non-negotiable. It really helps her move her body. It brings about fun and play and connection. It's regulating. And it is a freaking non-negotiable in our household. Like we just have a dance party each night. And that is not anything that we're going to see on any list anywhere, but it's just something that fits based on what I know of her and like our relationship and everything else. So I love this question because I feel like it brings in that like inner healing intelligence that I feel like we all have in our bodies, clients, caregivers, but we don't see it because it's like blocked by so many things or because we've been taught by the world to not necessarily privilege it. So as you can imagine, you can also be having these conversations with clients around how to integrate. And then I think of it as like front door, back door, how we're kind of integrating all together. So after you have established behaviorally what you're working on, then you look at how you bring in emotion. So I know that I've had people ask me in the trainings before, like, why is behavior coaching first on, I'm just going to pop up the slide again quickly. Like, why is behavior coaching first on the nuts and bolts when in all of the trainings, we always talk about like emotional support. We talk about pretty much everything before we talk about behavior coaching. And it's because in order to recover from mental health concerns, quite often we need to change behaviors. The thing is that if it were as easy as changing behaviors, we would just like throw that sheet of, recommendations for behavioral strategies to caregivers and we'd be good to go, but it's not that easy. So we need to identify our targets behaviorally, and we need to identify who we have to work with to support the behavioral change. But then we get into what I think kind of makes EFFT is the marriage of emotional support with that behavioral change. So the very first thing that we work on with caregivers, which is one of my favorite things to do in the behavior coaching component of teaching EFFT to caregivers in groups or in sessions, is help them learn how to respond emotionally to their loved ones' resistance to their implementation of behavioral interventions or expectations. And so, after you talk to the caregivers in the caregiver only session, like, okay, so we're going to work on less screen time. What does that look like? And maybe you make a SMART goal with them on how that's going to look for their kid. Then I'll say to them, like, okay, so let's be realistic here. How's this going to go? Because one of the top reasons why people don't maintain the limits that they set is because of the reaction from their loved one that then triggers something in their nervous system. Or maybe this happens to me in my life a lot. Like they're just too tired to maintain the limit when their child is like a brilliant debate artist, which is my child. And so it just like doesn't happen. And so rather than setting this beautiful goal and everyone kind of like hoping it'll work, but let's be real, like kind of knows it won't really work, but you're talking about the right thing, have that transparent conversation. Okay, so let's be realistic. What's your kids going to say to this? How long is it going to take for them to actually get into the rhythm of this? And what are some of the factors that we haven't talked about that are going to maybe happen when you make this shift? Like you're all of a sudden changing up a dynamic. And we know that when you shift something in the system, everything reorganizes. So you help them identify what the kid is going to say. Like, I don't want to recover, or I don't want less screen time, or like, I want my iPad, or I don't want to go to my freaking appointment, or like, I don't want to have family dinner, or whatever it is. And then you support them to create emotion coaching statements around that thing. So this is maybe a bit of a different way of considering teaching EFFT to caregivers, which is that rather than just teaching them emotion coaching as a general skill that then you make more specific, you identify what you want to teach them to emotion coach, and you teach them the skill while you're creating the emotion coaching statements, which to me feels a lot more efficient. It's not necessary for everyone, but I find that this way it makes it personal, it makes it efficient. And honestly, one of the biggest barriers that I think comes up for clinicians with emotion coaching is when the parent is like, I don't want to do this emotion coaching thing. And I think one of the reasons why a parent is like, I don't want to do this emotion coaching thing is because we teach parents emotion coaching as like a way for kids to feel seen and heard. And maybe we talk a little bit about the neuroscience, but we don't actually show them how it's going to help them to have those changes that they're trying to make in their kid. So it just feels like one more thing we're adding on that's like the nice therapy thing to do versus something that we're teaching them that will actually help the implementation of the behavioral change. So I find this way of teaching emotion coaching, honestly, to have way less blocks from caregivers, because you're showing them where it's going to get them. Like, this is going to get you from point A to point B, and this is why we're doing it. And then you can pull in some more of the information around teaching it. So just a thought there. So you work with them around creating the script. I'm not going to get into this too in depth because we literally on page 1 of 3 and we have 15 minutes left and I want time for questions. But, when we are doing emotion coaching, I don't like to leave parents ever feeling like they're stupid, to be honest with you. And I think sometimes what can happen is that we don't come in close enough to co-create the script, and parents haven't yet flexed that muscle and really built that muscle of validation. And so if emotion coaching is a new concept to you, or maybe if it's a concept that you haven't used a lot, I would recommend rewatching some of the videos on Mental Health Foundations about emotion coaching. Or to be quite honest with you, just like come to another core if you can schedule wise manage it and financially. And we do have group rates and student rates and all of that. But I think that we can, like, it's never too much learning emotion coaching. So essentially, when you're teaching people how to emotion coach, you want to co-create the scripts together and practice it pretty much until you feel like it's silly that you've practiced it so much, but what you're doing is creating new neural pathways in the caregivers. And when I practice in session, I'll say to caregivers, I'll be like, okay, I want to make this really uncomfortable. Once they get a handle on it and they have the script and you've practiced it a few times, I'll say like, so how bad is it going to be? Like, how is your kid really going to respond? And when your kid does respond, what are the things that they say that like stops you in your tracks? And then we practice that, and I'll get them to be their kid first and do it so I can experience it. Then we can create a script. But then I act as that kid and I'll be like, okay, my goal is to flood you, or my goal is to make you cry, which sounds horrific. But I'm like, I would rather have you have that experience in my office so I can be like, time out, take a breath, and then emotion coach them, and then practice again. Because, it's physiological when we get triggered. It's not cognitive necessarily. And I think what I've seen happen far too much in my own practice earlier on, and still with people I supervise and with caregivers we work with, is that they get the concept cognitively. They've like memorized it, they could teach it, but they're not prepared for what happens when they get activated interpersonally. So if we can practice it interpersonally, they're going to be more able to kind of hold their ground. So I just want to put that out there. So after you look at that, we also support the caregiver to create emotion coaching statements around urges in their loved one. So many of the clients we work with have kids who, have different behaviors and urges. And so things like, I want to cut, I want to kill myself, I want to run away, like anything essentially that a child struggles with being triggered to do. I work with caregivers to create emotion coaching statements around that. And as mentioned earlier, ensuring experiential practice of these scripts. So as you can imagine, this is not like a one session thing. And this is why I like having caregivers for a few sessions on their own before I do much else, because identifying the goals and doing probably in like one session with caregivers after you've like gathered all the information, you can set behavioral goals and then work on one emotion coaching statement. But it's not going to give you much time to practice. It's not going to give you any time to be like, hey, you tried it. How did it go? How did it not go? And so on. So you're going to need a few sessions for the implementation of this. After you talk about those emotion coaching scripts around engaging in symptoms, not wanting to do things, then what you want to do is you want to looking at emotion coaching scripts to respond to their loved one's stress or distress. Because we know that stress, distress is emotional fuel for symptoms and problematic behaviors. And so by recognizing what some of those stressors are, for example, maybe it's they have someone at school that they really don't get along with. I'm thinking about my own daughter, like for her, it's playing with more than one friend at a time at school. And that's something that really stresses her out. And she'll come home and like, if she's having a hard time with that, it's something that causes her to go into a bit of paralysis. And so that would be something, so anything, exams, like going between co-parenting houses, anything that is really causing distress in their lives. And I think the reality is that what we're doing by teaching emotion coaching is we're helping caregivers practice having the hard conversations that in our society we don't often have. And it doesn't have to be perfect. And so having a bit of a structure for it is a really nice way to learn how to step into the arena when maybe these caregivers were never taught how to have these conversations, or maybe their kid is quite rigid in the way that they are about things, and they'll just be like, I don't want to talk about it. So we have to help them get creative with how to get in there. Oh my gosh, we can talk about that all day, but we don't have time. After that, or similarly, you can identify emotional states that are fueling behavioral issues and symptoms. So for example, some of the kids we work with of any age, they have extremely, suppressed anger. I see this a lot in like OCD, anorexia, and ongoing suicidality. Quite often there's a lot of suppressed, and it can be in other presentations as well, but quite often there's a significant amount of suppressed anger. And especially in kids who seem like they're good kids, but then they're like vibrating inside. And then also things like sadness, hopelessness, and so on. So you can help create emotion coaching scripts around those things. And then finally, or maybe not finally, I would say this would be like the first thing to look at, is creating a script for the parents if they think this is going to be an issue, to respond to their kid when they're essentially like, stop talking to me like my therapist, Or why are you talking to me like that? Or, some parents, this is me as a parent, are more psychologically intrusive than other parents. I find that these are kind of like the jellyfish kangaroo on the caregiver traps. And so if they are that type of parent, no judgment, because literally I'm the queen of that type of parent, they're going to maybe have a harder time emotion coaching because their kid is just freaking sick of them talking about the emotion stuff and asking about the emotion stuff. And so working with them on like timing and amount of actually stepping into these things, but also working with them to respond when their kid is like, why do you talk to me about this all the time? Or like, why do you keep asking me this? Or like, I've told you I don't want to talk to you about this. So again, having those candid conversations of like, this sounds really good in theory, but let's bring it into your family and your child and your relationship. And what are some of the things that aren't being spoken that we need to consider that could make it go sideways? So I just feel like we're setting caregivers up to feel more resourced when they do step into, these moments with their loved one. So that honestly could take you a few sessions, the first 2 pages. That said, EFFT has 3 other modules to it. So at any time during the treatment, consider a therapeutic apology to strengthen the power of the caregiver's efforts to support their loved one or to support the release of their loved one's anger, pain, or self-blame. So therapeutic apologies are one of my absolute favorite interventions. It's used to augment the relationship when it feels like you're doing anything and everything you can, but the relationship just needs a little boost. So it has nothing to do with anything been done wrong. It's used to help caregivers release their own self-blame as an intervention that doesn't even involve the kids. It's used as an intervention to acknowledge the emotional culture of the family, which most families, especially in North America, because we live in such an emotion avoidant society, are quite emotion avoidant, or they could be more emotionally attuned than they are. And so it's a way of explicitly talking about this and setting the scene to shift things moving forward in a way that won't have the kid being like, you're weird. But it also is used to support caregivers to support their loved ones when there has been pain in the past. So I've definitely worked with families where there has been a significant amount of ruptures when they've been trying to support their loved one's mental health. And maybe those caregivers are holding on to certain things, being like, if only I hadn't have done this, or like, I wish we'd done this differently. Or maybe the kid is like, you messed up here, and so now I don't trust you. And so therapeutic apologies are also helpful for that. And so they're really an as needed intervention. And the way that we can assess for if they're needed or not is based on when we go through all of this and we're doing the emotion coaching, is there something stopping the emotion coaching from having like the full impact? And if so, look at that. And then the last thing I'll say, and then I'll open up for a couple questions, is that throughout treatment support to the caregiver, we do want to help them move through things that are going to impede their efforts to offer behavioral and emotional support. And so working through blocks would be helpful for this. And so this is a list of all of the ways that we work through blocks in EFFT. As mentioned, if you don't have EFFT training, come to a training. I'm doing a 3-day actually in December with Adele. That's going to be a lot of fun. And the 3-day has chair work in it. So you'll get like the full shebang. But if you don't, that doesn't fit for you for whatever reason, there are videos online that I believe Lisa posted. So thank you, Lisa, that go through these. And a really great way of seeing these, as mentioned earlier, is that 4-part prevention series for caregivers, because it goes through a lot of these. And then at any point, if you're triggered, of course, working through clinician blocks is a really important piece. So in a nutshell, this is how we put EFFT together when working with families. It's starting with those behavioral and those emotional pieces. And then anytime that you're having a hard time moving forward with those in any way, we consider pulling in the other pieces of the model. So that's that. Thanks everyone for bearing with me as we dove through that. We have 4 minutes left, and I would love to just open up for any questions that you have, and I'll stop recording.